It is 2 in the morning in the emergency department.
Hmm.
A child comes in with what looks like a classic mallet finger after a sports injury.
Right.
The distal tip of the finger is dropped. They cannot extend it. So you put in a splint, advise some rest, and send them home. Congratulations. You have just missed an open, contaminated physical fracture,
Yeah.
and you have likely condemned that child to a permanent growth arrest.
Yeah, it's a classic trap.
Welcome to your high-yield revision deep dive. If you are a resident preparing for the FRCS in plastic surgery or, staring down the barrel of a similar set of rigorous board exams, you are in exactly the right place. We are skipping the banter today and jumping straight into the absolute most critical traps and principles of the pediatric hand.
Precisely. I mean, your time is an incredibly scarce resource right now, so our mission today is laser-focused. We are dissecting pediatric hand and physical fractures.
Straight to the point.
Exactly. We will start by establishing the core principles of remodeling. Then we'll move into a biological breakdown of the Salter-Harris classification. And finally, we'll deconstruct specific, highly testable clinical scenarios. Things like the Seymour fracture trap you just mentioned.
Oh yeah, that one is huge.
It is. And the classic trapped in a door phalangeal neck fracture.
Before we unpack the clinical mechanics of all that, I want to strongly encourage you to hit the follow button on your audio player right now so you never miss one of these targeted revision sessions. And hey, if today's deep dive gives you an aha moment that clarifies your exam prep, please take a second to rate the show. It makes a massive difference for us.
It really does. And for those of you who want to completely bulletproof your revision, securing a premium subscription is the necessary next step.
That is exactly right. That premium subscription is your direct key to unlocking our exclusive Journal Club and Clinical Cases episodes. You absolutely need those in your arsenal to see how these theories actually play out in real-world board scenarios. Okay, let's unpack this. We need to start with the foundational rules.
Right, the basics.
When you're evaluating a pediatric hand fracture, the overarching rule, the absolute baseline from which your entire clinical algorithm operates, is that the vast majority of these injuries are managed non-operatively.
That is the crucial starting point. And, the fundamental reason for this overwhelming non-operative bias comes down to a single, powerful anatomical structure, and that's the physis.
The growth plate.
Exactly. The presence of the active growth plate means that the pediatric bone possesses an inherent biological capacity to remodel deformity as the child continues to develop.
Right. But the board exam won't just ask you if the bone remodels, right?
Yeah.
They were going to demand the specific parameters of that biological forgiveness.
Oh, absolutely. They want the specifics.
So let's set the stage by exploring the exact criteria. What are the specific measurable conditions that give a pediatric hand fracture the absolute greatest potential to remodel with growth?
Well, there are 3 golden rules of remodeling potential you must commit to memory, and they all rely on mechanical and chronological alignment. First, the remodeling potential is exceptionally high when the angulation occurs exactly in the plane of adjacent joint motion.
Okay, wait, let's visualize the mechanics of that first rule because I want to make sure we understand the why. When you say in the plane of adjacent joint motion, you are essentially talking about the natural arc of a hinge, right?
Yeah, that's exactly it.
So if a finger joint is designed to flex and extend, and the bone is bent in that exact same up and down direction, the joint can essentially absorb or accommodate that deformity while the physis does the slow work of correcting it over time.
That is an excellent way to conceptualize it. The plane of adjacent joint motion is the mechanical hinge.
Okay, so that's rule 1. What's rule 2?
Second, the potential is greatest when the fracture sits in close physical proximity to the physis itself.
Makes sense. Closer to the factory, basically.
Right. And third, the optimal scenario requires the patient to be a young child who still has many years of remaining skeletal growth ahead of them. So you have the mechanical hinge, the physis is the biological engine driving the correction, and the age of the child provides the chronological runway.
I like that. The hinge, the engine, and the runway. You need all 3 for optimal spontaneous remodeling. It's like a young sapling bending toward the light. If it's in the natural plane and has time, it fixes itself.
Exactly.
But let's push back on this biological engine concept, because board examiners love to test you on the limits of biology. An engine generally only drives in one direction. What happens when the chassis is twisted?
Yeah, that's where you run into trouble.
Like, what are the specific types of deformity that have little to no remodeling potential, where you absolutely cannot rely on the growth plate to fix your problem?
You must exercise immediate surgical vigilance the moment you encounter rotational or angular deformities that fall outside that natural hinge plane. These specific deformities have almost zero remodeling potential.
So if the bone is twisted on its long axis, or if it is angulated sideways coronally rather than in the sagittal plane of flexion and extension, the growth plate is practically blind to it. It cannot untwist the bone.
Exactly. The physis is an engine of linear longitudinal growth. I mean, it is an extruder of new bone. It is absolutely not a rotational corrective device.
Wow. Right.
Yeah, a twisted phalanx will permanently remain a twisted phalanx unless you mechanically intervene to correct it. And this biological limitation brings us to the absolute surgical maxim you must carry into the operating theater and into your exams.
Which is?
You must always unconditionally respect the physis during any surgical intervention.
Always respect the physis. I mean, that underlying biological imperative is the perfect bridge to our next topic. Because respecting the physis is paramount to everything we do in pediatric and trauma, we need a standardized way to communicate exactly how the physis is damaged.
Right, which means we have to talk about the Salter-Harris classification.
It is unavoidable. You just cannot sit for these board exams without a flawless, intuitive command of this classification system. It dictates your entire management strategy.
100%.
The trap that a lot of residents fall into is just memorizing this as a dry list of numbers from 1 to 5. I want to map the biological destruction here. And critically, we need to discuss the associated frequencies because, these percentages are prime multiple choice material.
Definitely.
Let's start with the relatively benign end of the spectrum. Break down type I and type 2 for me.
Let's run through the mechanics. So a Salter-Harris type I is a fracture that shears straight through the physis itself, horizontally separating the epiphysis from the metaphysis without actually breaking bone. This accounts for roughly 6% of these injuries. It is purely a cartilaginous injury.
Straight across the growth plate. Got it. Now, what about type 2?
Now, type 2 is the massive statistical outlier. This is a fracture line that travels initially through the physis, but then turns and exits through the metaphysis, taking a triangular wedge of bone with it.
A wedge of bone from the shaft side.
Exactly. And this is the most common presentation by a very wide margin, representing 75% of all physial fractures.
Okay, stop right there. 75% is a staggering majority.
It's huge.
If you are guessing blindly on an exam, statistically it's a type 2. But I want to understand the why. What is the underlying biomechanical reason that the fracture line decides to suddenly exit through the metaphysis rather than just continuing straight across the cartilage like a type I?
It is a brilliant question, and it really comes down to transitional biomechanics. As you move from the cartilaginous physis into the metaphysis, you are transitioning into an area of newly forming calcifying bone.
Right, the transition zone.
Yeah, and under shear or bending stress, the zone of hypertrophy within the physis is weak, but the adjacent porous metaphyseal bone is also incredibly vulnerable. So the energy of the trauma follows the path of least resistance.
Ah, I see.
It shears along the cartilage, hits a point of tension, and just pops up through the fragile metaphyseal bone, breaking off that classic triangular fragment.
That makes perfect mechanical sense. The energy just takes the most structurally fragile exit route. So types I and 2 generally spare the critical reproductive layer of the cells within the physis.
For the most part, yes.
Let's pivot to the danger zone then. Talk to me about types 3, 4, and V.
These are the ones that demand your full attention. Type 3 goes the opposite direction of type 2. It is a fracture that starts in the physis and exits vertically through the epiphysis, directly into the joint space.
Okay, so into the joint, how common is that?
This occurs in about 8% of cases.
Okay, so type 2 goes up into the metaphysis, type 3 goes down into the epiphysis, and type 4?
Type 4 is a fracture line that traverses all 3 anatomical zones.
All 3?
Yeah, it starts above in the metaphysis, crosses vertically straight through the physis, and continues down through the epiphysis into the joint. This represents about 10% of these fractures.
I have to admit, this is where I would freeze up during a late-night consult. If I'm looking at
It comes down to anatomical disruption and the healing process of bone. Types 3 and 4, as you noted, both involve a fracture line cutting through the epiphysis and the physis. By doing this, you are not just disrupting the smooth articular cartilage of the joint.
Right.
You are creating a vertical channel that crosses the horizontal growth plate. When that vertical fracture heals, bone can actually bridge across the gap.
Across the cartilage.
Exactly. This bony bridge or cross-linkage essentially tethers the epiphysis to the metaphysis.
Ah, I see. It acts like a biological staple. If one side of the growth plate is stapled shut by this new bone bridge, but the other side keeps growing, The bone is going to wildly angulate as it elongates.
Precisely, that tethering is what causes the angular growth arrest. And then finally, we have type V. This is a severe compression or axial crush injury directly to the physis.
Just squished.
Yeah, literally crushed. It is quite rare, accounting for only 1% of cases, but mechanically it is devastating.
Because you aren't just tethering the factory. You are actively crushing the cellular machinery that produces longitudinal growth.
Exactly right. In all three scenarios, 3, 4, and V, the delicate architecture responsible for growth is directly compromised, whereas I and 2 typically leave that cellular architecture intact.
All right, this is incredibly clear. We have mapped the general classifications. Let's move into the specific, highly testable clinical scenarios where these physical principles are actually put to the test. Let's revisit that classic clinical vignette I threw at you in the opening hook.
Ah, yes, the 2 in the morning mallet finger. I'm ready.
So a 10-year-old child presents to the emergency department. You examine the finger, and visually, it looks exactly like a mallet drop finger. It is flexed at the distal interphalangeal joint, and the child cannot actively extend it. It looks like textbook run-of-the-mill mallet finger.
Classic presentation.
But we know this is a massive clinical trap. Explain the Seymour fracture, and fundamentally, why falling for the mallet finger diagnosis in a pediatric patient is a critical error.
This is undoubtedly one of the most dangerous pitfalls in pediatric hand trauma. A Seymour fracture visually mimics a standard mallet finger, but anatomically and biologically, it is a completely different beast.
How so?
Well, a true mallet finger, which you see in adults, is a transarticular injury, meaning the injury involves the avulsion of the tendon or a bone fragment directly at the joint space. A Seymour fracture, however, is transepiphyseal.
Transepiphyseal?
Yeah. It is a fracture that shears entirely through the growth plate of the distal phalanx, just distal to the joint.
Transepiphyseal, not transarticular. So the joint is actually fine, but the growth plate just below it has snapped. But why does it rest in that characteristic dropped posture? I always visualize this as an anatomical tug-of-war happening right at the tip of the finger.
That's a great way to look at it.
To truly understand the mechanics here, let's map out the forces, exactly which tendons are pulling on which bony fragments to cause this severe distraction.
The tug-of-war analogy is the perfect way to understand the deformity, because there are distinct, opposing muscular forces at play here. On the proximal fragment, which is the base of the fractured distal phalanx, the terminal extensor tendon is firmly attached.
Okay.
It actively pulls that proximal fragment dorsally, pivoting it upwards into extension.
So the extensor tendon is aggressively pulling the top half of the broken bone up.
Yes. Meanwhile, the FDP, the flexor digitorum profundus, tendon inserts further down on the distal fragment. It is actively pulling that distal portion volarly, curling it downwards into flexion.
The extensor pulls proximal and up, the FDP pulls distal and down.
Precisely. The fracture is literally being pulled apart, violently distracted by the normal baseline resting tension of the patient's own tendons.
So this is not a fracture that you can just gently push back together and ignore. It is being actively held open by the patient's own anatomy. And beyond the bone, there is a massive soft tissue component to this trap. You mentioned earlier that treating it like a closed injury is a mistake.
It is a devastating mistake. A Seymour fracture is almost always an open fracture, and it critically involves the nail bed. To understand this, you have to visualize the epinicial fold, the pocket of cuticle tissue at the base of the nail.
Right.
In a Seymour fracture, the proximal edge of the nail plate is violently torn and often sits superficial to the epinicial fold.
So instead of being tucked neatly into the skin pocket, the base of the hard nail plate has popped out and is sitting on top of the skin.
Exactly. And because that seal is broken, the fracture site is directly exposed to the outside environment. If you simply apply a mallet splint over this without looking closely, you are burying an open, contaminated physeal fracture.
Which guarantees infection.
Oh, absolutely. Infection and subsequent growth arrest.
So as the resident in charge who has successfully identified this as a Seymour fracture, they've spotted the trap, what are the definitive non-negotiable management steps required to treat this correctly?
Well, because of the soft tissue interposition and the open nature of the wound, it requires a mandatory sequential surgical checklist. Step 1, thorough irrigation and debridement. You absolutely must clean the open wound and aggressively wash out the transepiphyseal fracture site.
Wash it out completely.
Yes. Step 2, anatomical reduction of the fracture itself. Step 3, meticulous repair of the nail bed laceration.
The nail bed repair is not just cosmetic here, right? It is structural.
It is entirely structural and non-negotiable, and that leads to the final step, the replacement of the nail plate. You must physically tuck the native nail plate, or a medical substitute if the native one is destroyed, deep back into the epinecule fold.
It essentially acts as a biological lid on a pressure cooker. It seals the injury from infection and splints the soft tissue.
Perfect analogy.
But from a bony perspective, is washing it, reducing it, fixing the nail bed, and replacing the nail always enough to hold the reduction against that massive extensor versus FTP tug-of-war we just mapped out?
Not always, no. If, after executing all those soft tissue steps, you find that the fracture remains unstable, if those tendons are still successfully distracting the fracture line, then you must escalate your fixation.
Okay, so what do you?
In that scenario, an axial transarticular K-wire must be passed down through the tip of the finger to rigidly hold the reduction against those deforming forces.
Excellent. That is a comprehensive breakdown of an incredibly dangerous trap.
Let's shift our focus to another heavily tested, extremely common pediatric mechanism of injury. This is a scenario residents will see time and time again in the emergency department.
Oh yeah, the door trap.
Exactly. A child presents after violently trapping their finger in a heavy door. What specific fracture pattern are we immediately suspecting with this crush mechanism, and what does the resulting deformity actually look like on examination?
A crush injury in a door jamb, particularly in a young child, should immediately trigger your suspicion for a phalangeal neck fracture. A phalangeal neck fracture, just so we are perfectly oriented, where exactly on the bone are we looking, and what is the visual hallmark of the deformity?
We are looking at the very distal end of the proximal or middle phalanx, just proximal to the flared condyles that make up the joint.
Right before the knuckle joint, basically.
Yes, and the classic defining deformity associated with a phalangeal neck fracture is that the small distal fragment containing the condyles is usually angulated dorsally, tilting backwards and pointing upwards into extension.
So the tip of the bone has snapped at the neck and tilted back.
Yeah.
Let me push you on this to get to the functional consequence, the so what for the patient. If that distal fragment is angulated dorsally into extension, how does this actually translate to a long-term functional deficit? What specific joint movement is physically compromised by this altered geometry?
It creates a severe mechanical blockade. You have to visualize the geometry of the joint. Because that distal fragment is tilted backwards dorsally, it entirely alters the rotational arc of the joint surface. Functionally, this bony prominence results in a physical block to incomplete flexion at the PIPJ, the proximal interphalangeal joint.
Ah, I see the mechanics of it. The geometry of the bone is physically altered, so when the child tries to make a closed fist or bend that joint, the bone actually hits itself. It physically blocks its own path to volar flexion.
Exactly. The dorsal angulation creates a hard, bony stop. If you miss this angulation in the emergency department, the child will permanently lose the ability to fully close that finger into a tight fist.
That is a major life-altering functional deficit to miss. So how do we ensure our management prevents that? How does the treatment algorithm for a phalangeal neck fracture change based on the initial degree of displacement?
There are two distinct, rigid pathways based entirely on your radiographic findings. If the fracture is genuinely minimally displaced, it can be managed non-operatively with a splint.
Okay, that sounds pretty straightforward.
It sounds it, but this non-operative pathway requires intense, unforgiving vigilance. Minimally displaced phalangeal neck fractures require weekly x-rays to ensure they do not subtly slip into that dreaded dorsal angulation.
Weekly x-rays. That is an intense follow-up schedule. Why do we have to babysit that reduction so closely? Is the neck region really that inherently unstable?
You absolutely have to babysit it because the deforming muscular forces acting across that small fragment are incredibly insidious. I mean, it can look perfect on day 1 and be completely displaced by day 7.
Wow.
Now, if the fracture is clearly displaced upon initial presentation or if it slips during your weekly monitoring phase, the pathway changes immediately. Displaced phalangeal neck fractures mandate a closed reduction in the operating theater and absolute securement with a K-wire.
So you can't just try to splint it back.
You simply cannot rely on a conservative splint for a displaced fracture in this specific, highly unstable anatomical neck region.
Splint and watch like a hawk with weekly x-rays for the minimally displaced. Reduce and pin immediately for the displaced. That is crystal clear. Okay, let's take a step back and synthesize the physiological logic we have covered today to ensure these concepts are deeply locked in for your exam prep.
Always good to recap.
We started by exploring the biological engine of the physis, detailing the 3 rules of remodeling. The plane of adjacent joint motion acting as the hinge, the proximity to the physis, and the runway of remaining growth.
Right.
We mapped the biological destruction of the Salter-Harris classification, specifically highlighting why types 3, phi, and V are so dangerous, because they tether the growth plate with a bony bridge or crush the cellular machinery, leading to arrest. Then we broke down the transepiphyseal trap of the Seymour fracture, the opposing tug of war between the extensor and FTP tendons, and why you must treat it as an open fracture, tucking the nail plate back in as a biological lid. Finally, we dissected the trapped-in-a-door mechanism of phalangeal neck fractures, visualizing how that dorsal angulation creates a devastating mechanical blockade to flexion at the PIPJ.
Yeah, that's a great summary. And when you synthesize all of this biomechanical and physiological data, I want to leave you with a final overarching concept to mull over before you sit for your boards.
Give it to us.
Consider the sheer paradox of the pediatric hand. The physis is a remarkable double-edged sword. On one hand, it is the very cellular structure that gives these fractures their incredible, forgiving power to remodel over time. It is the ultimate biological safety net.
The engine we talked about.
Exactly. Yet simultaneously, it is their greatest vulnerability. The entire surgical algorithm we utilize, when to operate, when to pin, when to just observe with weekly x-rays, is dictated entirely by the urgent need to avoid permanent physeal growth arrest. It is the absolute source of the healing and the source of the greatest potential complication. Keep that duality at the forefront of your mind as you review your clinical cases.
It is a perfectly balanced mechanical and biological system, and respecting that balance is how you pass your exams and protect your patients. Before we sign off, I want you to drop down to the show notes right now. We want you to leave a comment or a specific question about today's material. Does the biomechanics of the Salter-Harris tethering still trip you up? Let us know down there.
We'd love to hear from you.
And one final reminder, if you are serious about taking your FRCS revision to the next level, make sure you secure that premium subscription for access to our Journal Club and Clinical Cases episodes. Seeing these concepts applied to complex, multi-stage clinical vignettes is what bridges the gap between theory and passing the boards. You won't regret it. Keep studying hard, trust the depth of your preparation, and we will catch you on the next deep dive.